I'm really pleased to introduce Dr. Mark Hall. Dr. Hall and I work on a number of projects that are PrEP-related. Mark Hall completed his fellowship in infectious diseases at the University of British Columbia. He went on to complete a postdoctoral fellowship with the Canadian CIHR HIV Clinical Trials Network. He now works as a clinician and research scientist at the BC Centre for Excellence in HIV/AIDS. Please welcome Dr. Hall. Thanks, Mark.
Well, I actually don't have to give a presentation anymore because everything that I was going to say has just been said by my two excellent panelists, so hopefully we can actually go straight to a group discussion very soon. I think when I look at it from my point of view, I look at it from a very biomedical standpoint, and I have to say that's my background as a clinician, and I think there are lots of people in the room who bring other strengths to a more combination prevention approach. But when I look at it, I think we have to look at the issue as 70% of new diagnoses in Vancouver are still in MSM. So what are we going to do about that? That is really the main crux of the matter for me as a doctor, is how can we keep our community healthy, and for people who want to have active sex lives without a risk or fear, as people have said, how can we prevent transmission? And I think this is really where we start to have a conversation about combination prevention. We look at some of the structural things, and this conference is really touching stigma and other issues that really affect how we interact with systems, and look at some of the biomedical things that the system can now offer. And this includes what we're doing at the moment for people who are positive, which is treatment as prevention. We know transmission is related to HIV viral load. The higher your viral load, the more likely the virus is in terms of being able to be transmitted. And if you're on successful antiretroviral therapy, this risk is reduced substantially. So that's definitely one tool that we have available to us, and this is what the province has started on in terms of its treatment as prevention approach. But what if you're negative? What can you do on top of condoms, or in addition to condoms, or instead of condoms, depending on what your sexual practices are, if you're a negative guy and want to stay negative? And this is really what Maxime has led us through, which is looking at some of the biomedical prevention strategies in terms of the evidence behind pre-exposure prophylaxis. And if we look at MSM-related trials, there are three major ones: IPREX, PROUD in England, and the IPEGAY, which is still going on in France and Quebec. IPREX and PROUD, as you know, were a daily dispensing of Truvada. IPREX is intermittent. That trial has not yet been concluded. I think there are no guidelines that would embrace intermittent use at the moment, but that may come as the trial concludes and we get more substantive confirmation that that may be a potential strategy. I think if we look at IPEGAY, we know the average number of pills taken was 16 a month, if I remember correctly, which means that people were actually using it quite regularly. So it's not, I don't know if we can extrapolate to the person who's having like one sexual sort of encounter on a weekend once a month yet to say that that data covers that group of people. We can see in San Francisco that some of the stigma is fading. There's a massive upswing in the last year or so of uptake of PrEP, and we can see in the 667 people that are PrEP users in one healthcare organization, which is Kaiser Permanente, that they've seen no HIV seroconversion so far, which I think is really at a population level and a public health level a very useful piece of information that we have when we look at tools for HIV prevention. If we look at Quebec, they've seen a massive upswing as well. Basically over 500 people just at Clinic Lectuel as of November. Most of these would fit the categories that we see. And so we're seeing in our other provinces that this is something that I think the stigma will start to fade away as this becomes a normative strategy that people can use to protect themselves or use as part of their looking after their health. The barriers, I think, are what I'm interested in. The people that I see, I think I look at it from a point of view of resilience. They have overcome the stigma. They've overcome the challenges to come into the door and see me, which I think is something that we really should try and say. What have those people been able to do that other people have not been able to do? For me, it's a resilience issue. They've overcome the first barrier, which is the lack of community knowledge. If we look at Momentum, we've just performed a study with Nate Lukowski, who I don't know if he's in the audience, but is the key investigator there. We found that if we looked at 2012 to 2014, only 18% of our MSM enrolled in Momentum in Vancouver were even aware of PrEP, which is not a very high number, which tells us there's a lot of work to be done if we really want people to start accessing these sorts of prevention strategies. In Toronto, where they've started this exercise a few years before us, they looked at this in 2011, about 14% of MSM were aware. But I understand now from my colleague, Dr. Daryl Tan, that that number has skyrocketed in the last few years. And now, if they've run the survey most recently, I think over 70% of people are aware of PrEP. So there's been a big upswing out east. I'm not really sure where we are in British Columbia in terms of dissemination of knowledge within the community. And so for the people that have come through my door, they've probably gone to their doctors asking for PrEP. I would be very curious to know how many family doctors have recommended PrEP as part of their routine conversation with their patients, as opposed to the conversation going in the other direction, which is somebody saying, I think I qualify for PrEP, how do I get it? And I think that's, for me, I think something that we have to learn from. These are very resilient people who've taken the negative of their prescribing physicians, where their family doctors have been like, PrEP, what is that? Like, what are we having this conversation for? Do you really need it? The visceral responses that Jody described, I think people have gone beyond that and said, I'm still interested in PrEP. I think it's a prevention strategy for me. And I think that's a very powerful statement and a powerful group of people that we have to learn from. So the barriers you've covered already, which is a lack of physician awareness. I think finding a GP who's willing to prescribe an off-label drug is quite challenging at the moment. And if you don't have a GP who's willing to prescribe it, can you find a GP who's willing to refer you to somebody who is willing to prescribe it? Also a challenge. A lot of people who end up seeing me have tried multiple times. They've gone to walk-in clinics, they've asked their own family doctor, they've gone through a very circuitous route before they found somebody who's willing to refer them on or be even aware of somebody who's willing to prescribe it. And so I think this is another avenue where people really have persisted in terms of coming in. And I think that's, again, something that we have to look at. At a systems level, we're trying to address this. And we've tried to look at this in a number of ways. So we're working with Vancouver Coastal and BCCDC to say, can we facilitate PrEP referral pathways either within Vancouver Coastal or Vancouver Coastal through to us, so we can help people access PrEP a little bit more easily if they want to. We've developed, from the CFE side of it, local PrEP guidelines for clinicians, so that physicians who are starting to prescribe PrEP now have a local guideline that they can point to help them in terms of the monitoring and evaluation that has to go on for people using PrEP. And I'm working with Jody and a number of other stakeholders in the room. I see Julie at the back. And with Dr. Daryl Tan in Toronto, we have funding now to develop at a national level guidelines for recommendations for post-exposure prophylaxis and pre-exposure prophylaxis. So hopefully we can bring this conversation out into the mainstream medical conversation and really, again, make it a normative part of how you approach your healthcare. Finally, I think the financial ones are really the elephant in the room in terms of how we move forward from this. You need private insurance, as has been mentioned multiple times. And I think even when people come and see me and they think they have private insurance, we discover not every healthcare plan is the same. A lot of plans don't cover off-label medication, as you said. Even if it's covered, the copay sometimes is excessive. So if they'll cover 80% of it and you still have to pay $200 a month, for some people that's financially just unaffordable and people aren't able to access it for financial reasons. And of course, the lifetime maximum, as you covered. The other thing from a healthcare provider that's very, very frustrating is every company is extremely different in terms of what they require for documentation. And the amount of letter writing that has to go back and forth can sometimes start to become a bit of a hassle. So companies require a rejection letter from the provincial plan to show that you've tried to access it through a provincial program, which of course doesn't exist. That's fine, but then a lot of companies will come back and ask for some additional letter from you to say why you're prescribing this medication. And I find that actually highly difficult to deal with, because that's a clinical decision between you and the person that you're working with. Why does their insurance company need you to justify why you're prescribing this medication? It's a barrier, I think, sometimes. I mean, we do it, and I haven't had anybody reject it. I don't know in your experience, but I find that additional requirement for information is a little bit off-putting. So I don't have any solutions in this arm. I think here we need to await Health Canada approval for Truvada for pre-exposure prophylaxis license. I think this will make it a lot easier for insurance companies to cover it. I think that will remove some of the off-label barriers that physicians raise when they look at bringing it in. We know the company has applied to Health Canada for this approval, and it's just a matter of time now. I think the question will be, from a company point of view, if they do have Health Canada approval, will they develop a patient assistance program to help people with co-pays in a similar fashion as is being done in the States? And ultimately, obviously, we have to work with our partners in the room at Vancouver Coastal, PharmaCare, and the CFE is to say, how do we develop a public program, and how do we develop criteria for a public program that won't as has been seen in other situations, perhaps add to the stigma of accessing PrEP. I think public programs have to balance the need to target high-risk populations or subpopulations where we're going to see the best efficacy or effectiveness for the cost. But at the same time, how do you do that in a way that isn't stigmatizing? It's a huge barrier for us to come up with. I think a lot of that is driven by the cost of the medication, because the cheaper the medication is, the fewer barriers or criteria you have to put in place. And so this is something that we'll have to keep in mind in the next couple of years when this medication becomes generic. It may be a very different funding situation. So those are just, I guess, my perspectives, and I think the panel discussion would be something that I'm looking forward to.